Good afternoon, everyone. And I, Dr. Ananya Prabhu, chest specialist at NITRD in New Delhi. Welcome you all to the 113th session of e-NISCHIT, and I welcome you on behalf of my panel from ECO, Dr. Jyoti and Rakesh ji, who helps, who is the backbone of our e-NISCHIT clinics. And today clinic is going to be very, very interesting, and because we have going to discuss a very important component in our TB battling, in our challenge in ending TB and getting to the target, and that is prevention of TB in the detect, treat, prevent, and prevent part. This prevention part we are going to talk about today, and to enlighten us on that, we have very privileged. We have with us Dr. Ramesh. He's a public health specialist with CDC India. Thank you, sir, for joining us today. So I'm sure today's session is going to be very interesting because we all have sitting at ART clinic, and otherwise also we all have a lot of doubts and questions about TB preventive therapy and what to give and what to not to give, and we still are not totally convinced on that part. And we have doubts like drug resistance and how effective would it be, and adding to the pill burden. So just to dispel all those thoughts, we want to give you the right perspective, and we are very glad that we have Dr. Ramesh Allam with us to give us a dialectic on that. TPT, I'm sure, is something all of us have to keep updating our knowledge because there's been recent change in guidelines. So this is going to be an update on that. So we will start our dialectic now without further ado.
Thank you. So this is Dr. Ananya, and rightly told that this is an important session that we are looking to see that India actually is put up the goal which is really high, set a high standard of 2025 elimination of TB, that this becomes an important area where we need to prevent HIV infection, tuberculosis. The objective of this session, basically what we have is that all the participants will be able to understand what is HIV-TB co-infection and how the dynamics are between HIV and TB. The second important thing is how do we screen PLHIV coming to our ART centers for tuberculosis, and the TB preventive therapy that we are providing currently, and what is the guidance that we received from NACO recently through the technical resource group meeting that has happened, and everybody has got an operational memorandum to each state have been provided. When to start, when should you fully start within your state, and what is the time? So those things will vary between state to state, but I'll give some examples of that. Then we will also see about TPT recording and reporting tools that we have within the program. The session objectives that we have discussed is on TB co-infection, screening among PLHIV, and what is the newer guidance that we have for TB preventive therapy, and what are the tools that we have. So coming to how HIV and TB actually fuel each infection rates, if you see, if you have a HIV positive patient and if you look at what is happening to tuberculosis, on the left side of the screen, you will see that the risk of developing TB is relatively higher among PLHIV. And there is almost 3 to 10% people develop TB, and TB infected PLHIV you have. And it's also HIV-TB has a higher mortality than those who are HIV negative TB patients. So your mortality is higher, chances of developing tuberculosis is higher among PLHIV, and even a recurrence rate is higher among them. And as part of the guidelines, when you're doing this post follow-up of these TB cases for at least 2 years, some of the states have already some data that yes, there are patients, around 8 to 10% of the patients, they see a recurrence of TB among PLHIV. And there is also a higher mortality among. Then you look at what among TB patients, if you see what is the effect of HIV in them. So if you see among TB patients, there is more of TB bacilli where there is an increased, which causes more inflammation and then a rapid HIV replication among them. And progression of HIV infection increases just because of the rapid replication that you see. And this is the most common opportunistic infection among people living with HIV, and the mortality due to TB is higher. So one common message that we all need to take up is, yes, if you are going to prevent TB, your number one, transmission of tuberculosis is reduced, and also among PLHIV, the chances of getting tuberculosis is reduced, and then the risk of transmission of HIV through a higher viral load that you have whenever you have tuberculosis, even that can be prevented. And you see within general population what is relatively higher. If you see the pulmonary TB and extrapulmonary TB in general population, approximate proportion that you see is around 80 to 20%. So what you have higher is a pulmonary TB, but when you see among PLHIV, you see more of extrapulmonary TB, relatively higher extrapulmonary TB in that. And this again is one other common thing that you see, even if you look your own HIV TB records after this session, what you will understand is you see more pulmonary TB in your centers, just because we do not have that good tools to diagnose extrapulmonary TB within our limitation. That is the only reason we are not able to see more extrapulmonary TB in our centers. But the truth is there is more of extrapulmonary TB among PLHI, and increased chances of risk of tuberculosis is really higher among TB patients. Now, with this background of understanding that each disease fuels the disease transmission and mortality rates, there's no change in identifying patients or screening patients for tuberculosis. There's no change in that. So whatever we had learned in the past years, in the recent capsular training, everything stands good for screening of patients. So we have different strategies to prevent TB. Number one is intensive case finding. So whenever we talk of intensive case finding, we need to remember that the patients who are cough symptomatic needs to be fast tracked. This is just to cut the disease transmission even in that OPD setting wherever the patient is sitting. And then we rapidly refer that patient for diagnosis for tuberculosis through NAT testing and other appropriate investigations. Second important thing, we need to remember prompt and effective treatment of active TB. Whenever anybody is diagnosed to have tuberculosis, we tell all the centers there, you start it immediately as you know the patient's status of tuberculosis, so that he or she doesn't carry that infection within the household or the community and even at the ART centers. And early ART initiation among PLHIV, this we have told n number of times that most of you do not start ART in these patients. You are still waiting for 2 months. So all the guidance is changed. Again, go back to the ART guidelines. You see that ART initiation you can do as rapidly as possible. Even with patients with a low CD4 count, you need to start. And then airborne infection control, and the key important thing that one of the key strategy that we have to prevent tuberculosis is the TB preventive therapy. That we will discuss in the next subsequent slides. So first thing first, we need to understand how TB screening should be done. There's always a high turnover in ART centers. So if somebody is hearing this for second or third time, just excuse me. But for the benefit of people who are not doing it regularly and who do have new staff, this again is a refresher for you all. So we need to remember, very important, that there is difference between a patient who has HIV and who do not have HIV for referral. So among patients who have HIV, that is at all our ART centers, among adults and adolescents, there is a difference for 4 symptom screenings. You see carefully on the left is for adults and adolescents, current cough, fever, weight loss, and night sweats. And on the right for children, if you see, the difference is poor weight gain and history of contact with the TB case. There you don't have weight loss, but you have poor weight gain. Night sweats is not part of children. Now there are many people who actually come from other areas of TB, or you might be dealing with HIV negative, and possibly you would have joined the ART center relatively new. Here we talk of current cough. We don't give the duration of cough. We don't say 15 days, 1 month, nothing. You say currently, you ask the patient if he says, yes, I have cough, or is he coughing? just take the patient as 4S positive. Now, if any one of these 4 symptoms are present, we say it as 4 symptom positive. Not all, but any one of these 4, then we say patient is 4 symptom positive. And then when you say yes, they are called as 4S positive. That's what we all register in our patient visit register or HIV TB line list or any other record in the ART center. This is called 4S positive. Any one of these 4 symptoms for adults and any one of these 4 symptoms for children. And I will not go further into what to do. But if it is 4S negative, that means if the patient is not presenting with any of these 4 symptoms, the next step what we do is whether the patient is eligible to be started on TB preventive therapy. That is the second decision tree that we take into. And when we start looking at the decision tree, the first thing we need to again reassess is the contraindications of TB preventive therapy. And if there is no contraindication, we start TPT. And if there is a contraindication, we defer TPT. So from this slide, there are 4 key messages that I want you all to carry home as there is difference in of history when we do it between a patient who is having HIV and who does not have HIV. Second important thing is any one of these 4 symptoms, not all, some of you have still that impression. The third important thing, when you diagnose or when you start screening with any one of these 4 and if they are 4 symptom negative, then the next important thing is to rule out if there is any contraindication and rule out for active TB. Only then we start TB preventive therapy. These are the 4 important things. Now, from this slide, the important thing that we need to understand is now what are the contraindications for TB? That we will come in the subsequent slide. But what you need to also look at is how do I record all these in my ART center? What is that record I need to look into and what is that I have to put? So this again is another key element. Without you writing anything in the records, we cannot prepare our monthly report. So your source registers are important. So the care coordinator has a register called as a patient visit register. They can do it for as positive, negative there. Then a screening by a staff nurse. The staff nurse screening is a bit detailed. So actually, these 4 symptoms, if any one of these symptoms is present, the staff nurse will check off. If there is a weight loss, yes, she checks off weight loss. If there is a night sweat, yes. So from this slide, what we can see is there is a patient coming with a 4 symptom screening. That's what the care coordinator had put as 4S positive. Then the nurse is saying that the patient has weight loss and night sweat. That's why she checked off those 2, which you can see on the screen. And then the decision whether the patient really has symptom or not will be taken by the medical officer, and that will be noted in column 13 of the white card as 4S positive or negative. So this is how you have to record in the ART center. These are the different places and different people who would be recording and reporting. Now, once you have identified that the patient is 4S negative, the important step what we thought is why we should be doing it. And we have discussed in the first slide that at least in Indian settings, about 50% of our adult population, not patients, population will have latent TB. And INH is one of the effective drug that is helpful in prevention of or this infection turning out into a frank TB infection is really high when you do not have this prophylaxis in place. And it also prevents reinfection of tuberculosis. For example, in my first slide, I have already told that the recurrence rates are higher. It could be a reinfection which was not there. So that is one important thing that can happen either endogenously or exogenous. So for any sort of reinfection, INH is one important drug that is shown to prevent that reinfection, either through open case or through an open exposure. Now, who should be offered? This we have discussed, but two key important points again I want to draw from this slide is look at the age group. So if there are children aged less than 12 months of age diagnosed HIV and who do not report poor weight gain, fever, and all those four are unlikely to have active TB and should be offered TPT. I'm sorry, more than 12 months. So for all practical purposes, if you really are able to rule out active TB among more than 12 months or more than 1 year of age, then you could start TPT. But if it is less than 12, it is a bit difficult just to do all this screening and this. So this really requires a specialist care in terms of understanding whether you completely rule out tuberculosis or if there is a likely contact of TB. All those should be really done thoroughly. So I think the guidelines clearly specify that a specialist opinion is really required if you are trying to look into less than 12 months with the HIV exposure or diagnosed with HIV. How do we move forward? So we have seen that contraindications of tuberculosis is one key step in our decision tree. So until now, the patient is 4S negative. So the contraindications for TBT, one obvious reason is they should not have an active TB disease, number one. Number two is they should not have active hepatitis 2, signs of peripheral neuropathy. Just because we are going to put INH, which has this notorious side effect of, again, a peripheral neuropathy, you do not want to add fuel to fire there. So this is one other thing you want to see where the patient really has a severe peripheral neuropathy, even when you have 4 symptom negative. And the other things are symptoms of peripheral neuropathy and then poor adherence to cotrimoxazole. This is not a strict contraindication as such, but this is like if a patient is not taking cotrimoxazole prophylaxis properly, that is a prophylaxis, and TPT is also a prophylaxis. So possibly that patient needs to be really monitored for TB preventive therapy if you really want to start. So we do the behavior change of taking cotrimoxazole regularly, and then we bring in TPT in these patients, and poor understanding by the guardian. There is one other important thing. Whenever we start considering contraindication, we also have here a patient exposed to an MDR TB case. So this we removed it from here. But if you look at whether it is a contraindication, not a true contraindication, in the next slides you will see why we have taken it out. But no harm if you already have something in your material or the desk that anybody contact with an MDR TB case, what do you do? So that thing we will have some answers in the current IPT guidelines. So hopefully everybody have seen this guideline that has come up. This is a recent revised guidance on TB preventive therapy, where NACO had shared this office memorandum to all the states and possibly all the state AIDS control societies or the district AIDS prevention control units who are part of this call. You would have got this. So we will now stick on to this guidance, and I'll try to just explain what this guidance means and who should be part of this regimen. And I'm giving a disclaimer. I'm not telling start this from tomorrow or when. The decision of starting will be taken up by your respective SACs. Okay, so NACO had clearly written in this. So that will be the last slide of this session. But starting immediately, no, it is a decision of the state AIDS control societies and the state TB officer in your respective states to start this one, because it has to be based on the stocks of IPT that you currently have in the state, number one. Number two is whether there is a sufficient procurement done for TPT, for 1 HP already in the state. So the revised 1 HP guidance, you can see we have just tried to make it simplify the entire OM into these 4 buckets. The first one is talking about if we have to provide 1 HP to patients who are aged more than 13 years, here we are giving 1 HP. And when I say 1 HP, H is for INH, which you all were providing for 6 months now. And then the additional drug is rifampicin. And this is going to be given for daily for 28 days. Sorry. What is very important here is, some of you have asked in the prior sessions too, in the same e-NISCHIT one. So should we have a dose modification for DTG? For patients who are on dolutegravir, should we modify the drug, or should we give that additional 50 milligram dose that we are giving to patients whenever we start ATT, we are giving that additional dose of 50 mg. Should that be given for these patients who will be put on rifampicin? No. So there is no need of this additional dose of 50 mg only for if you are looking at patients for these 28 days. So this is one important thing, different from TB treatment that you're providing now. And there's a second group of patients like age less than 13 years, ANC and breastfeeding women, and PLHIV who are on protease inhibitors based regimen. These group of patients will continue to get INH for 6 months. So one contraindication or who should not be offered with 1 HP are patients who are age less than 13, ANC or breastfeeding women, and PLHIV who are on PI based ARV regimen. What should they be offered? They should be offered INH daily for 6 months. Now, there is other group of patients which I just told you during my slide on contraindications. Earlier, when we had 6 months of INH, patients who had contact with an MDR TB case, we were not offering them any active prophylaxis. But now, if there is a PLHIV having a contact with the drug-resistant TB, then you see a regimen now for them that is 4 months daily on 4R, that is rifampicin, and then 6 months, or you have a 6 months daily levofloxacin, depending on what are the drugs that are, whether it is a mono failure or you have both the things which are failing. But what I want you all to draw is, if there is an exposure to a contact with a DRTB case, is there a prevention mechanism now currently? Yes, we have, and these are the guidance that is being provided. And what is happening to children less than 13 years of age who successfully completed treatment for TB? Now, this is like a child had completed tuberculosis treatment. However, the child is less than 13 years old, but just completed TB treatment. This is sort of a secondary prophylaxis that we are providing for children less than 13 years age who had taken only INH in the past. So we will give an additional 6 months. Whatever we are continuing now, the same guideline will continue for less than 13 years of age immediately after treatment for active TB. So this is one that will remain. Take some time, digest this one important slide. Though you may not be doing it from tomorrow, but the changes that you have in our current guideline is more than 13 years, you need to provide 1 HP. Less than 13 years, continue whatever you were doing earlier, that is 6H daily for 6 months, INH for 6 months. Along with them, if you have antenatal pregnant women and breastfeeding women or patients on PA-based regimen, they should also be offered INH for 6 months. And there is a sort of good news for patients who had a contact with the DRTB. We still have some preventive measure for them. So this is all that you need to remember for the newer guidance. Now, once you know who should be offered, the question is, now what are those pills I should be offering? So whenever we say 1 HP, these are all called as short formulations for TB preventive therapy. For example, you will be hearing 1 HP, 3 HP, 6H. These are nothing but that 1, 3, 6 are the duration, how long we should be giving. So it's like almost a month you will give 1 HP. 1 month of daily rifampicin plus isoniazid. 28 doses it has. And who should be offered? You are seeing. Now the dose is like 300 milligrams per day of INH and rifampicin is 600 mg. So listen carefully. Most of the formulations that we currently have, even if if you're going to start from tomorrow, you have a fixed dose of INH and rifampicin, that is 300 milligrams and 300 milligrams is a fixed dose that we have. But a PLHIV should be getting 600 milligrams. So we also need to give the 300 milligrams of rifampicin in a separate tablet. So you will have a fixed dose of INH and rifampicin 300 mg in one fixed dose tablet, and a separate molecule of rifampicin 300 milligrams separate. So effectively, an adult should be getting 2 pills. So one fixed dose pill and the other is a rifampicin. And what if you do not have a fixed dose in some states? Maybe if you have INH 300 milligram, that is given as one pill. Rifampicin, you just have 300 milligrams, you give 3 pills. That is going to increase the pill burden. So this is very important for the states to understand. When you're procuring it from your states, please do understand that if you take up a fixed dose combination, it is going to help the PLHIV because you're going to reduce the pill burden. If you by mistake procure like INH rifampicin single molecule in the bulk you procure and you forget to procure a fixed dose, you're going to add another one more additional tablet to the PLHIV who should we take. So you're going to increase the pill burden. Very simple. We forget in our daily routine, but this is an important mechanism that we need to remember when we are procuring. And when we procure, we don't procure for 10, 20 patients. You procure it for 1 year and that's all. Mistakes cannot be modified until unless you complete that entire dose. So this is one important thing for procurement purposes, and states and districts, when you're calculating your drugs that you need, this is what you have to bear in mind. So this is how, not that every strip comes like this, I'm just showing you how currently some of the drugs are available within the program setting for rifampicin and INH. So this is a glimpse of what is that 1 HP. 1 month daily, 28 days pregnancy, it's not known. That's why we are not offering. Interaction with ART, yes, compulsory. All PIs we do not want to give. And even when you do it with efavirenz and all, we are not still pushing this for NNRTS. Now, one special situation, for example, you have some of them listening to from Northeast or from places where you really have injecting drug use as a core problem in some of the patients that you come. So there we need to really be a bit cautious when we start offering 1 HP, because there could be some withdrawal of opiate that could happen and you have the opiate symptoms coming in. So one important thing is do it with caution. We are not saying it is contraindicated, but you need to really be cautious about whenever you are doing. Or sometimes there may be a requirement whenever you have to increase the dose of that opioid substitution therapy that we are doing, possibly with buprenorphine or methadone, possibly not part of the program now, but buprenorphine is part of program, so we may have to increase the dose of that. Just remember, whenever you have injecting drug use, active injecting drug use, and you're planning for 1 HP at that point of time, we really need to be careful and observe the patient. And
it's probably not with the 6H therapy.
Yes, it's not part of the 6H. And then one important thing is possibly in all the OST sites that we have, this is one important information that we need to pass because patients, if they are taking drugs from OST clinic, they will not come to the ART clinic again to get there 1 month. Possibly you will decentralize that 1 HP there. But key important thing is at OST sites, if patients are on ART and getting 1 HP, or if there is tuberculosis there and if they are getting, so Please remember, we need to provide this special guidance. All states and districts who are part of this call, we need to bear in mind. And if you have link ART centers, and if there are centers that are having what is it called, decentralized process, if you're giving in a TA site ART, there also we need to inform all those medical officers. Now, very important thing, we also had several discussions when we had 6H in the program. If a patient is taking for so many days, should I discontinue? Should I again start 28 days? So for all that, this guidance is there. Now, for example, a patient you have started giving this 28 day, a patient has come on his pill pickup date. You have counseled the patient that this should be taken, and you have given the 28 days of drug. The patient is coming back to you after, they come back only after the next 28 days. So they are coming back for their next refill to your ART center. And at that point of time, what you have understood is the patient has taken less than 23 drugs. That is, he or she brought back to you some 10 pills of this 1 HP. So what do you do in this case? So do you really want to again restart 28 days? What? So the guidance is very clear that if the patient has taken at least 23, that means they would have missed 5 days. Don't encourage the patient to complete those 5 days as soon as possible and add those missing doses to the total treatment duration to come. So very simple is tell that person to take those next 5 pills as soon as possible. The next slide you will see how much time I should give, what is that as soon as meaning, and all will come there. But if somebody has missed the pills for more than a week, okay, if more than 7 consecutive doses were missed, consider restarting the complete course of 1 HP. So the course is very simple. For the patient, it is simple because there's no need to take for 6 months, just take it for 28 days, you're finishing TB preventive therapy. Than patients who have taken for 6 months. This is an advantage to the patient. But as a counselor or a healthcare provider, the very important thing, the message that we need to drive is adherence again is very important here. So not to miss. If they are missing more than a week doses, then they will be again restarting the entire course. So if more than 7 doses were missed intermittently, we need to ensure that they complete within that maximum time. What is that maximum time? 8 weeks from the first dose they should be complete. And if 1 HP is not possible, consider discontinuing it and offering 1-3. That's not part of the program, so we will delete the last bullet, but the first 2 are important. More than 1 week, what you do, and if they miss all 7 days consecutively and they are also having pills for more than 1 week, you please restart that. And if they are taken intermittently, but if they are having this, then what we do is we need to understand that they need to take it in the maximum duration that will come next. But important message to the counselors when you are asking about pill intake, this is a very important question that we have to ask the patient is, if they are bringing back the pills and showing you 10 drugs or 7 drugs, you have to ask them this question whether it was consecutively they have not taken for the last 2 weeks or 1 week. The answer is yes, then restart. If they say no, here and there I have missed, then it is. So this is an important judgment you need to make while you be counsel. And since the regimen is cut short to such a short duration, being really precise on our questioning the patient and giving a message is really important. Now, this is the slide I'm telling about. When do you say that the patient had completed 1 HP? That is 80% of the recommended doses. That is 23 of the 28 tablets if the patient has consumed within 48 days of 1 HP. Okay, within 40 days if they are able to take it, then we say, yes, the patient has completed 1 HP. Similarly, we had discussed the same definitions for 6H. When do you say it is completed? We also gave some a grace period there. So here you have some more grace period in terms of not just 28 days, there is some grace period of 40 days you see here, even if you have taken 80% of the recommended doses. So when do you say the patient is lost to follow when you want to give it here? Here we say TPD interrupted by a person for 10 consecutive days for 1 HP is basically he lost the treatment. So he should be restarted. 7 days also should be a restart. And anything you have doubt, there are current guidelines, 2021 guidance you can see. These are TB guidelines, not the HIV 2021 guidelines. Our HIV guidelines still we have the older 6H, but the TB guidelines you refer, 1 HP is given there, and this is where you will find.
Why this loss to follow is not 7 days? I mean, anyway, we are restarting the treatment. Why is it even 10?
So what they say is, even when you are not bringing the pills, and if the patient just says 10 days, then you consider. In cases, not everybody is bringing the pills back. That is all. And all other recording and reporting tools are all the same. That is, we need to enter in NITRD. And I showed you all our screening tools starting from patient visit register. Then you have our HIV-TB line list. Then you have a TB register. You have a white card section 13. And we should also go into the NITRD module. So everything is the same except the duration. Pills are different from in the current 1 HP. Now, this is another question that we frequently get. What if there is an exposure to a drug-resistant TB case? So here are some options that we have. So 4 months daily rifampicin for contacts of TB patients with INH monotherapy or polyresistance and rifampicin susceptible. So the key here is it has to be a rifampicin susceptible, whatever is it, a resistance that you have. Only then we are offering it. Now, suppose you have rifampicin resistant, then we go in for 6 months daily levoflux. So these are the two things. But again, these cases are the ones that you need to get some specialist suggestions and recommendation within your own institutes, wherever ART centers have, you definitely have a chest clinic there. So getting a referral there and getting the recommendation is really important, at least in the initial stages, whenever you start this sort of preventive therapy in these group of patients. Now, we have seen that 1 HP should not be offered to children who are less than 13 years of age. So these are a couple of references that we have. Why? Because there are very limited data on the daily dose of rifampicin in this age group. So yet we need to have some established data coming in on pharmacokinetics and safety among these age groups. So we are not currently offering this as a part of our program. But a recent observational cohort study, I showed a good safety and feasibility, but still we are not giving it just because we do not have that sufficient evidence to take it up at our national level. So this is one important thing. We need to bear in mind, less than 13 years, we continue INH for 6 months. And why pregnancy and breastfeeding women? There is again limited data on the pharmacokinetics and safety of this in pregnancy. So we are not offering 1 HP again here. And preliminary safety data, this regimen in pregnant women, you have some guidance, but as part of WHO and our CTD and ACP guidelines, we are not offering for breastfeeding and pregnant women 1 HP. Again, why PI-based regimen? The same consistent answer that we have. Why are we increasing the dose of BTG? Why are we increasing the dose of efavirenz? Why are we also not saying it should not be taken with oral contraceptive pills? All this rotates around the cytochrome P450 enzyme induction mechanism that rifampicin has. So there is a reason PIs, along with PI, you give a rifampicin 1, you are going to reduce the dose of PI to such a level that it goes to a subtherapeutic dose, and the effect of ART is no more in that patient, and you get a rebound viral replication, and the patient fails that particular antiretroviral therapy. So you do not want to tinker or do anything to an ART there. So you just offer a 6H in this patient to continue over on PA-based regimen. So the same answer holds good for if they are concomitantly on oral contraceptive pills. Just take care. again the P450 enzyme reduction takes place. So possibly you need to look into this another very important drug-drug interaction that may come in. Now, what is the dosing for children less than 13 years of age, or if you are giving a secondary prophylaxis immediately after TB treatment completion in children less than 13? Here you just remember again a procurement issue. I have personally seen in one state, they have not procured anything for children 100 milligram tablet. So until this becomes part of your procurement, then you can start giving a child something. Otherwise, you'll have to start adjusting your adult doses, trying to cut them half, give quarter of them. So all these can be just prevented by understanding that you will require some different dose for a child, and possibly there is a 100 milligram available that should be procured for children, specifically in the States. Now for follow-up, there's nothing changed except the 28 days when they come back. Very diligently we need to ask the patient whether they have taken it consecutively. Is there a miss of 7 days? And if there is a miss, give them that within 40 days they need to complete it. So all this real counseling that you're offering for 6 months, keep the same pace. Don't tell the patient that it is just 1 month, you complete it. No. Be really as stringent as possible, however you are on 6H, because here you are adding additional pill here. Remember that. Even if we are giving FDC 300 rifampicin and 300 of INH, there is additional pill that is going to add in the form of a single molecule of rifampicin to these patients. So there will be a relative increase in pill burden. So you also should tell the patient, when do you really prefer to take this TB medication? Maybe in the afternoon. If you are taking morning the single dose of TLD, then possibly you can take it in the afternoon, evening. So this sort of things we need to start guiding the patient when those additional pills can be taken with ease. Now, special situations, this is only for 6H, not for 1H, not for 1HP, and these are the same things. I will not go into this, but same important thing, if a patient has taken IPT for less than 1 month in total, what should I do? Thing is, ensure they have completed 6 months from then, start afresh. Similarly, like how we have dealt it, this is for 6H, which you will have to remember only for less than 13 patients who are on protease inhibitors for pregnant. And I'm reiterating, this is almost a third slide on recording and reporting formats. This is one important thing. We will know only if the patient is offered just by looking at the white card, we will understand. Now, this is the last but a very important slide for all of you who are here on the call, states and district teams, if you're on the call. See, the guidance is very clear. SACS will be calculating the doses of TPT that is required for our patients and giving it to the state TB cell. So it's not that SACS will procure. Here it is that you need to have a combined meeting between the state TB department and the state SACS, or at the district level, DTCO and the DAPCO team should sit together, assess their estimate of the drugs or the IPT that they require. You need to procure for both 6H for some patient groups, 1HP for some patient groups. When I say 1HP, it is like a fixed dose and another single molecule of rifampicin. And you also have to see for DRTP contacts. And children less than 13 years, the 100 mg. Only when the procurement progress, everything is in place, then the national program is giving in this operation memorandum, office memorandum, to start the process. And there should be a detailed guidance to each facility offered by SACS again for how to start, where to record, report, everything in detail. So, thank you for your patience listening.
Thank you, sir. You made things quite crystal clear for us, because all these guidelines, the way you have gone through them, giving us both the practical approach and what needs to be, what essential points we need to remember. Thank you so much for that. So one gray area is that generally in a place like setup like us, most of the patients are like we come to know about HIV when they have already got active TB. So they're referred from a TB center. So this secondary chemoprophylaxis is still a gray area. We don't know, like we wait for their treatment, completion of treatment. Should we immediately give them and we the 1 HP or should we not, or that age of 113 years? Can you just throw light on that?
Yeah. So basically, if you look our TB guidelines, what the NTP guideline says, I mean, when we were giving 6H to give immediate prophylaxis after TB treatment for 6 months. So that we are considering it as secondary prophylaxis to prevent relapse or recurrence. So that is one thing. But in this 1 HP, what we are saying is once in a lifetime, if somebody more than 13 years had completed 1 HP, we are not offering them again a 1 HP, again, even immediately after the TB treatment. So
Okay.
that secondary prophylaxis part for 1 HP is not being recommended now, this guidance.
Okay.
And what we have also tried to see is the guidance that is coming on secondary prophylaxis is from the days when we were giving TB treatment as an alternate regimen. So there is no effective systematic analysis or an active studies conducted when you have given a daily regimen of 6 months of TB treatment and offered after that 6H as a secondary prophylaxis. Is there a real benefit? So this is still a gray area in terms of do we really need to give secondary prophylaxis in patients on 6H?
Yes, because there's a lot of patients in my
Yes.
center who got 6H long back.
Correct.
So now thinking of them as HP1 HP candidates.
Right. So 1H, if they have not received, we still consider that as a patient did not receive in the past. And if they have received 6H in the past, we will not do it again.
Even if they were not adherent, but like if the completion was like
doubtful, completion was doubtful,
so
definitely.
then we can give 1 HP.
Yes,
but if they are successfully completed, then we don't need to think of 1 HP.
Very important question. So I think this is important. Now from tomorrow, if some state is starting or shortly, don't over enthusiasm again. Don't give patients who have completed their 6H. Don't start this one.
What sir had said, I just want to add one point. The secondary prophylaxis is still being considered for children less than 13 years. So secondary, those who have just completed the ATT, we can continue with the 6 months of 6H in children who are less than 13 years. So secondary prophylaxis will be considered in that group only. PLHIV more than 13 years, secondary prophylaxis is not a part of guideline now.
Yeah, but these more than 13 years, they have received 6H in our center now. So that's what we were thinking. And but most of the time, the data is such that some have completed 60%, some have 80%, some had a lot of areas, a lot of adverse drug reactions. So we were not sure whether how effective it was. So then I asked him whether that 1 HP is worth considering in that one.
And one more point I just want to reiterate about the follow-up, the post-treatment follow-up or the prophylactic treatment. We need to follow up the patient for next 2 years just to check whether they have been breakdown into the active TB or not. So on 6 monthly basis, we need to do the follow-up of those patients who have completed the TBT regime.
So on ground level, we also see like we said that there's 60-40 extrapulmonary and pulmonary. So there's a different HIV population. So what I feel is that sometimes we miss we may miss by symptoms. So ultrasound abdomen generally we screen. So because when we have to rule out TB, it has to extrapulmonary also has to be ruled out. So that's something which we need to stress upon, that just not rule out the pulmonary TB part. Because lymph node to dikh jata hai, but sometimes abdominal lymphadenopathy and we think that it's a pill burden, patient not absorbing. We just think it's a symptom of HIV or maybe the drug say gastritis or it could be TB abdomen as well. So that's what we try to send those patients for ultrasound abdomen where you have the facility, where at least if a hospital is attached, we should definitely try to be more aggressive on extrapulmonary part. We can discuss the post-test
Yeah.
answers.
I'm sure all the participants got the answer during the didactic only. It was so informative. So now we'll answer the questions. The question one was, in the context of revised TPT guidance from NACO, select the correct patient group who are eligible for shorter course, 1 HP, TPT as a TPT. The correct answer is option D. PLHIV who are more than 13 years of age, not pregnant, and not a contact of MDR TB case. So all these patients will be eligible for 1 HP. So question 2 is, which of the following is the correct statement about 1 HP? So the correct answer is, the additional dose of DTJ is not required when on 1 HP. So no dose adjustment is required in such cases. So question 3 is, PLHIV completed 28 days of 1 HP and later had TB infection. So is secondary prophylaxis of TPT indicated? So correct answer is no. The secondary prophylaxis of TPT in PLHIV who have completed 1 HP TPT will not be eligible for secondary prophylaxis.
And one more thing that Sir had already stressed upon is the recording, because we need to collect data on this new regimen, and we really need to know how much percentage. We wish that it cuts down by 90%, the latent TB turning into active TB in HIV population. So does it really work that way? That can only come with then recording the data well, and because segregating the cases that it was successfully completed, or sometimes the treatment is not well taken and you blame it on the regimen. So that recording part has to be very, very robust, I feel. So that's one thing I want to stress upon. So with that,
So I thank our case expert today who has thrown light on the newer guidance on the TPT, and I'm sure all our participants will be benefited with this. And I thank our moderator, Dr. Ananya, who has moderated the session so well. Thank you, ma'am. Thank you, sir. And I thank my team, Rakeshji, who worked behind the curtain. I thank our ECO team who provides us the technical support. And last but not the least, our participants who make the show successful by their participation and translating their knowledge into their action while they're working at the ART centers. So I thank you all. Thank you.